I don't need to tell this audience that the dynamics of the pediatric HIV epidemic are rapidly changing, and we are moving towards an epidemic that is tilted more towards an increasing burden of HIV being amongst the adolescent age group for several reasons, including the fact that PMTCT is being scaled up and the adolescent HIV incidence in many countries is declining, so fewer infants are being born with HIV. But on the other hand, due to the scale up of pediatric antiretroviral therapy and the sort of presentation of long-term survivors in adolescence, as well as sexual transmission, has resulted in proportionally increasing numbers of adolescents in HIV care services as we go along. And this is likely to continue. So we do all know that the survival prospects of HIV-infected children have dramatically improved with antiretroviral therapy, with a 40% reduction in mortality, and since 2005. And HIV is now progressively becoming a chronic disease rather than a fatal one. And we also know that ART mortality is substantially reduced with antiretroviral therapy, but only 20 to 30% of exposed children are actually accessing early infant diagnosis, and large numbers of children are presenting with HIV and starting ART in later childhood. So this is shown very elegantly by the age distribution of pediatric HIV and antiretroviral therapy need over time in a model in South Africa. And what it essentially shows is the distribution of children with HIV by age in the year 2000, 2010, and 2020. And the blue ones are those ineligible, the green ones are those receiving ART, and the red ones are eligible but untreated. And what you can see, it's like a domino effect with increasing numbers of adolescents who are going to be ART eligible, and particularly the blue bits are going to disappear because everybody is now going to be eligible for antiretroviral therapy. And this assumes that about half of the infants are accessing antiretroviral therapy by 2 months in this model. So what is the consequence of all of this? So clearly, burden of HIV infection and timely antiretroviral initiation remains a pertinent issue. But also there are additional unresolved issues such as suboptimal control of HIV, and we've been discussing that today. There's also malnutrition and the long-term effects thereof, vaccine-preventable diseases, psychiatric morbidity, and also a really big question is whether ART is enough. And I'd like to just consider some of these issues as we go along. So we know that HIV has pro-inflammatory properties as well as immunosuppressive effects, and that HIV is associated with organ damage, which is partly a consequence of the timing of HIV infection, but also a consequence of the timing of antiretroviral therapy. So both those factors will come into play when we're thinking about organ damage. Also, children are expected to be on antiretroviral therapy for approximately 2 decades longer than in adults. And they're starting antiretroviral therapy when their physiological physiological mechanisms are still relatively immature compared to in adults, and they have got longer exposure to drugs. And these will again have impact on longer-term consequences of dealing with HIV. And this really emerging issue around premature malignancy risk in this age group. So I don't really have time to go through every single complication, but I just wanted to give you a flavor of some of the problems that we can anticipate to see and are seeing, and that need further study. So one important aspect is cognitive impairment. And we know that progressive encephalopathy in infant and young children does result in substantial improvement with immediate antiretroviral therapy in infants, as was shown in the SHARE trial. However, there is conflicting data in that no difference in cognitive performance was seen between those who had deferred and immediate treatment arms in the PREDICT studies. However, these children were older, and both groups performed worse than uninfected children. And we also know that residual cognitive and motor defects persist even with antiretroviral therapy in children who start ART in early childhood. In older children, and these, as I said, are becoming a bigger group, the deficits tend to be much more subtle and not those that we routinely identify in clinical services. And we don't have great validated and culturally appropriate tools. So there are defects in fine motor function, perceptual performance, quantitative abilities, mental processing, and language abilities. And these are critical for adherence, education, and career planning. And this is an issue that we don't pick up that easily in clinic and will have an impact on good outcomes. Moving ahead to hearing loss, the other complication that we commonly see is hearing loss. So in a study that was done in Zimbabwe recently, in 5 to 17-year-olds, of whom 89% were on ART for a median of 3 years, and the nadir CD4 count was 271 with a recent median CD4 count of 725. 32% had evidence of hearing loss, of whom total 11% had moderate to severe, severe profound hearing loss. And most of the hearing loss was most of those with hearing loss was due to chronic inactive otitis media, and 87% of the hearing loss was in those with chronic suppurative otitis media. What this is actually telling us is that many of the complications that children face, infective and non-infective, result in disabilities such as hearing. And these children often recurrently come to clinic and are given antibiotics when they come in with hearing loss, but we don't actually access hearing. And what I want to bring out in this session is the fact that, yes, antiretroviral therapy and viral suppression is an incredibly important goal, but we are going to be left with complications of HIV and its treatment. And it's important that we take a broader perspective and be thinking about the functional disabilities that are consequence of the impairments that occur in this age group. The other thing that I think previous speakers brought up was this issue around growth failure and pubertal delay. And we know that about 30 to 50% of children have growth failure. And in one study of several you could pick out, you found differences in height for age Z scores between comparing HIV positives to HIV negatives, and pubertal delay found in about a fifth of children. This is quite different from the malnutrition and the wasting that we see. This is really stunting a height for age problem. So, children not having linear growth. And this becomes particularly obvious in adolescents as children get their growth spurt. And I think, again, very elegantly brought out in the previous talks that, there is submaximal long-term catch-up growth, and this has an effect on their final height. And importantly, not just height, but also on their bone age. And this has an impact on bone mineral density, which will again be exacerbated by the effect of drugs such as tenofovir. And this is just a study that I would like to point to, which is the ARROW trial, where they looked at the effect of antiretroviral therapy on growth. And importantly, one of the key findings was that if you start ART later in childhood, you remain on a lower trajectory of growth. So that so you've pretty much missed the boat, really, if you're starting ART later in life, because you've lost quite a lot of your growth potential. And that's really important, as I said, because a large proportion of our children are actually not starting ART in infancy. And so even if you achieve even if you have some catch-up growth, your final potential will not be met. And clearly the reason I want to bring this up is because of the implications on also bone growth. So we're not just talking about linear growth, that's dependent on growth, also consists of muscle growth and bone growth, and that's critical for long-term outcomes. The other aspect of chronic complications that we need to think about is chronic skin disease. I think all of us see huge amounts of chronic skin disease. It's incredibly common, not in HIV-infected children only, but also uninfected children. But you have a very high odds of being HIV-infected if you've got skin disease in adolescence. And this is not just infective skin disease, but also non-infective skin disease. So, this young lady who presented with eczema that led to her diagnosis, and clearly long-term kind of scarring as a result of streptococcal infection, papillopruritic infection, eruption, as well as warts. One particular type of skin disease is this planar warts that we see very commonly, and it's associated with HPV 1 and 2 type, and tends to present in sun-exposed areas and is very difficult to treat. And when we biopsied this, what we've seen is the biopsy is very consistent with a condition called epidermal dysplasia verruciformis, which is seen very uncommonly in adults who've got a genetic predisposition to immunosuppression immunosuppression and results in malignant transformation in the 3rd and 4th decade. That's where this condition, these HPV types have been found. But we see it very, very commonly in our HIV-infected children. And again, something that we often see is that the warts might disappear, the sort of coarse warts, but these persist. And again, one might think that, well, it's a skin condition, it's not going to kill them, but again adds to this whole growing picture of multi-system diseases and conditions that are associated with HIV that these children are going to live with. Also, it is very, very identifiable as an HIV-associated condition and really marks these children out in schools. I also want to just bring up the issue around premature malignancy. We know that HIV-related cancers, Kaposi sarcoma, non-Hodgkin's lymphoma, and Burkitt's lymphoma have risen in incidence in older children. Also, there are case reports of premature malignancy, which are rare and atypical and tend to occur in older individuals. And, again, begs the case about whether we should be implementing the HPV vaccine in HIV-infected adolescents as well. The other issue I want to allude to, which I brought up earlier, is the effects of antiretroviral therapy itself adding on to all of these. So we've got the bone mineral density issues that might arise because of the use of tenofovir on top of the effect of HIV infection itself. And clearly also as we start using protease inhibitors, metabolic complications as well as renal toxicity. And it's important to bear these in mind again, and I will keep saying this, is because they are not something that we routinely screen for in busy HIV clinics, particularly in low resource settings, and something that's not immediate, and so it's not on our forefront, but again, something that we need to be thinking about as these children now enter adolescence and adulthood. The other couple of chronic complications that I want to allude to are chronic lung and heart disease. So this has been an area of my work for several years, and we've just completed this study, and I just wanted to show you some data that we presented at the Cape Town meeting in December, the lung meeting. And what we're seeing is that even in children who are antiretroviral therapy experienced, we see a very high burden of lung symptoms as well as poor lung function. So this was, we had 3 groups, an HIV uninfected group, an HIV infected group that was ART naive, and an ART experienced group that had been on ART for a median of 5.6 years. All the 3 groups were all in the 5 to 16 age group. What you can see is that 15% had an MRC dyspnea score of 15% had MRC dyspnea score of greater than 1, which implies, which is showing degree of breathlessness. 11% had desaturation on exercise, and 20% had an FVC Z score of less than minus 1.64. 4% had an FEV1 Z score of less than minus 1.64. Interestingly, what you can see is that despite antiretroviral therapy, you still had that, persisting defects in lung function in the ART experienced group. We would have expected this perhaps in the HIV ART naive group, but not in the ART experienced group. And also what's clearly very obvious is that the rates, the proportion of those with poor lung function is much, much higher than the HIV uninfected group of children. And interestingly, also what we found, which also is just a point of importance, also reflected in the other studies, is that despite antiretroviral therapy, stunting remained a big problem in the treated group. And importantly, what we are seeing is that the disease that causes poor lung function is not really due to what we've classically understood as causing lung disease, chronic lung disease in younger children, which was lymphoid interstitial pneumonitis. In fact, on CT scanning, we found that less than 1% had features that would be consistent with lymphoid interstitial pneumonitis. What we're actually seeing is much more of mosaic attenuation and bronchiectasis, volume loss, and some emphysema. So these are not features that we have seen in lung disease previously. So this is classically what we see, these patches of mosaic attenuation on CT scanning, and also areas of bronchiectasis. And this would be very consistent with small airways disease or what is classically known as bronchiolitis obliterans. And there's a very strong association between FEV1 and mosaic attenuation. In fact, this was the only predictor of mosaic attenuation. And chest X-ray is extremely insensitive for identifying the pathology that we are seeing now in older children. And the CT may identify preclinical disease, because clearly we've seen a lot of CTs, disease on CT that is not necessarily translated into symptoms. What we're also finding, as you've seen in the previous slides, is that what we're actually seeing is much more of a restrictive defect rather than obstructive spirometry. And this might probably be due to the fact that these children not only have poor growth, linear growth, they also have poor lung growth. And this might promote what we call a small lung, and that might contribute to the restrictive defects that we are seeing. The other thing I just want to point out is that emphysema is very rare in young people, so it should prompt clinicians to think about HIV if they see it on CT scanning. And so there's a shift in the spectrum of chronic lung disease that we are seeing now in the era of antiretroviral therapy in older children and adolescents. So in young children, we classically used to see in the pre-ART era lymphoid interstitial pneumonitis, diagnosed relatively easily, even with chest X-ray and clinically, responds very well to corticosteroids and antiretroviral therapy. In this age group, where we are seeing small airways disease, it remains mostly unrecognized still, often recurrently treated for TB on the basis of chronic symptoms and lack of alternative diagnosis, and doesn't tend to respond well to steroids and persists despite antiretroviral therapy once established. And we've not going to show this data just now, but it is associated with development of pulmonary hypertension. And importantly, the other thing that I wanted to point out, and lovely work that's being carried on in Cape Town that's also demonstrating this. This is a study published in The Lancet in 2007 of tracking lung function. And what the investigators showed is that whatever lung function you start off with during your childhood, and which might be determined by smoking status, pneumonia, etc., is what you remain with for the rest of your life. So if our children get poor lung function due to HIV, then that is what they're going to stay with. So lung morbidity is not something that's just going to disappear once it's established. And basically, lung function tracks through life based on what's happened in childhood. Really, it seems to be a multi-factorial condition. HIV is associated with not only respiratory tract infections, but also growth can result in poor growth of the lung. Nutritional factors, malnutrition can affect the lung growth as well as put you at risk of infections. So all of these factors, including immunosuppression, as well as chronic inflammation, persistence of HIV and immune dysregulation as a result of infection, recurrent respiratory tract infections, and oxidative stress that often accompanies infections can result in chronic lung disease. And this is a model that's been put forward and postulated for chronic lung disease in adults. And I think it's a model that could fit very well in children as well. And we certainly need more studies to be able to understand the pathogenesis of chronic lung disease. It's not moving forward, Jason. Oops. I think I've... somebody there who can just bring the... Okay. This always happens to me. I'm jinxed at conferences. Right. The other thing is to say is that there are a lot of pathogenic studies that are going on, but very few actually correlate the pathogenic findings with clinical findings on spirometry. So there are a number of pathogenic mechanisms that could explain organ dysfunction, including chronic lung disease, but we do need to be correlating that with clinical findings. The other chronic complication that I want to talk about a little bit is cardiac disease. This is also a study that we've been doing in Zimbabwe, where we looked at, again, HIV-infected individuals aged sort of 6 to 16 years who'd been on antiretroviral therapy. So all of these children were on ART for a median duration of 4.7 years, and the median CD4 count was 726, and the vast majority was well suppressed on antiretroviral therapy. therapy. But what you can see is that despite relatively good immune status, good immune control, we find a lot of cardiac defects on echocardiography. So importantly, 38% had evidence of ventricular hypertrophy and 6% had evidence of ventricular dilatation. And we're not talking about small changes. This was 2 standard deviations from what should be normal for the parameters that were used to define this. And importantly, what was interesting is that ventricular dilatation was associated with having started art later in life, but ventricular hypertrophy was associated with having had a longer duration of art. And I found that quite interesting because it's showing out signals that basically not only HIV might be having some effects, but potentially drugs could also be having effects. And here we also found that nevirapine use was associated with ventricular hypertrophy. And a substantial proportion of children had dysfunction, systolic and or diastolic dysfunction, despite no echocardiographic evidence of structural abnormalities. So it's a clear signal that there is cardiac problems going on even in the era of antiretroviral therapy. Okay. And when we looked at the right side of the heart, and this is a poster that will be presented at the AIDS conference by Edith Majonga, we've seen that nearly a third have evidence of right ventricular dilatation and right ventricular dysfunction. But there was no association of this with lung function. Importantly, the association was mainly with left echocardiographic abnormalities, with a 2.5 odds of higher odds of having right ventricular dysfunction or dilatation if somebody had had a left ventricular abnormality, which implies that this is much more of a global cardiac disease rather than just a function of lung disease. Lastly, I just want to touch quickly on vaccine-preventable diseases. So we do know that there is low immunity to vaccines if somebody is ART naive, and that good antibody and lymphoproliferative responses do occur to revaccination once somebody is on therapy. But there's also loss of protective immunity over time, but we only mainly use correlates of antibody levels with protection. And there's a real gap here of research and very few specific guidelines on what one should do with adolescents and young people, particularly those who are vertically infected and have grown up with HIV from birth, in terms of whether there is a necessity for repeat dosing of vaccines while on antiretroviral therapy, what the timing of those vaccines should be, and essentially the effect of age at ART initiation and the response to vaccines. Also, what the correlates of antibody levels with immunity, real immunity are, and timing of vaccination after start of antiretroviral therapy. And again, these are things that don't come to the fore really, but we've had a couple of reports, for example, a measles epidemic in Botswana a couple of years ago amongst adolescents, and the ones that basically were predominantly affected by the measles epidemic were children who were adolescents, HIV-infected adolescents, the majority of whom were well suppressed on antiretroviral therapy. Importantly, what I wanted to point out is this very poignant picture that HIV-related complications result in lifelong deformity. These are some patients from my clinic, presenting with seronegative, burnt-out, deforming arthritis, somebody who had had a stroke at the age of 3, chronic uveitis that has left with a child with blindness, and a couple of really good studies, one from Malawi, which showed, compared the domains of disability reported by parents amongst HIV-infected children and their HIV-uninfected siblings. And basically, across most domains, the cases who were HIV-infected children really had higher proportions of disabilities in all these domains. And the odds of disability of any type was 8.4, odds ratio was 8.4 if one was HIV-infected. And similarly, a recent study done by the Jandiri program in Zimbabwe, where they've looked at screening in communities of disabilities amongst HIV-infected adolescents aged 10 to 19 years. And I think the numbers speak for themselves. 44% had any disability, 20% reported multiple disability, and hearing, visual impairment, mobility impairment, learning disabilities, and communication difficulties were reported in very high proportions. So just my penultimate slide, what this talk is really for is to have a plea in terms of the research priorities. We do need longitudinal prospective studies of prevalence and incidence of chronic systemic complications. These need to be controlled and we need combined cohorts with standard definitions and validated tools. And really what we also need is normative data. And as well as studying the impact of antiretroviral therapy and looking at virological suppression, we need to be looking at the disability and impact on function on these adolescents as they grow up, and thinking about the diagnostic and therapeutic strategies we will have to be addressing this. To my mind, and put very neatly by the WHO Constitution 1948, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I think that we need to have a broader approach at looking at HIV in terms of not only viral suppression, but also of the complications that arise. So in summary, high burden of chronic complications. I whizzed through a whole lot of complications. I really wanted to give you a flavor of the different disabilities that we are seeing as children grow up. And many of the factors that determine this are evolving. There'll be a potential impact of clearly in utero exposure to HIV and antiretroviral therapy, timing of infection, timing and duration of antiretroviral therapy, and also the persisting effects of HIV despite treatment. And we really need to be putting into place surveillance and taking into account of context. So apologies for going a minute over, but I think I'm allowed that given that the slides went awry a bit. And I'd like to acknowledge all the many wonderful people that I work with. Thank you very much.